Thank you. Thank you for introduction, Chairman. Good morning, everyone. I'm Jongwook Park from Korea Cancer Center Hospital, Seoul, Korea. The Korea Cancer Center Hospital is the first dedicated cancer hospital in South Korea, which was established more than 60 years ago. First of all, congratulations to the APPS 2025 and the 17th Uro-Oncology Congress of TUA. It's my honor to have the privilege to speak at the APPS TUA joint meeting in this fantastic city of Antalya, and I appreciate the warm hospitality and kindness from our Turkish friends. Today I'll talk about the treatment de-escalation for metastatic hormone-sensitive prostate cancer. Oh, okay. Okay. Historically, patients with metastatic hormone-sensitive prostate cancer were treated with ADT, including LHRH agonist and orchiectomy, to reduce testosterone to castrate level, but its survival benefit was limited, and most patients progressed to metastatic castration-resistant prostate cancer. However, since year 2015, the treatment landscape of metastatic hormone-sensitive prostate cancer had dramatically evolved thanks to the improved oncological outcomes of various doublet or triplet therapies, so-called treatment intensification. As you can see in this table, the doublet and triplet therapies prolonged overall survival by more than a year and a half. Although treatment intensification is good for patient survival, why do we have to consider treatment de-escalation? Because not all patients need intensification, and toxicity increases as treatment intensified, so that a singular treatment intensification could result in overtreatment for some subgroup. This is a landmark study of the intermittent androgen deprivation comparing continuous ADT published by Dr. Hussain, which neither proved nor disproved the non-inferiority of I8 intermittent androgen deprivation because of some drawback of its statistical design. But this result cannot be applied to the current situation because the study was performed before the treatment intensification era. The PSA response is a strong indicator of a patient's prognosis, and many clinical trials that employed treatment intensification consistently showed deep PSA response and fast PSA response achieved survival benefits. And as you can see in this graph, those survival benefits of patients with deep and fast PSA response were proven in a real-world practice as well. So deep responders who show radiologic remission may be allowed de-escalation. The metastatic prostate cancer has heterogeneity in its biology. It is well known from the ENZAMET and TITAN studies that intensified ADT with an AR pathway inhibitors didn't result in a survival benefit in low-volume disease. And we all know the ADT brings considerable side effects from hot flush, osteoporosis, fatigue, to thromboembolic disease, cardiovascular disease. Osteoporosis and fractures cause decreased quality of life and debility in patients, and their risk correlates with the duration of ADT. Also, AR pathway inhibitors cause various unique side effects, including skin rash of apalutamide, fatigue of enzalutamide, and hypertension of abiraterone. And the risk of cardiovascular events can be doubled by the AR pathway inhibitors in advanced prostate cancer patients. Then, when should we consider treatment de-escalation for metastatic hormone-sensitive prostate cancer patients? If a patient's PSA level drops under 0.2 at 3 to 6 months after ADT, or radiologic remission appears, it is a sign of a favorable prognosis, and these excellent responders may not need long-term intensification. When a patient suffers from side effects of ADT or AR pathway inhibitors, you should consider dose reduction or intermittent therapy. And some patients may not want to lose quality of life over a survivor gain, and tailoring treatment intensity through shared decision-making is necessary for them. Then how can we implement treatment de-escalation? There will be several strategies in terms of efficacy, quality of life, and economic cost. Considering continuous ADT plus AR pathway inhibitor is the standard of care, removing either ADT or AR pathway inhibitor or both can be a solution. The timing should be when PSA and radiologic response appear, usually after the post-treatment plateau of 6 to 12 months. The disease burden must be low, and there must be a deep PSA decline, and the symptom must improve. At the 2025 APCCC, more than half of the participants said that if patients had deep remission to systemic therapy and no side effects, they would recommend treatment interruption. And here are some relevant ongoing clinical trials. In the PS6 trial, metastatic castration-sensitive prostate cancer patients with a good response would be randomized to the de-escalation of systemic treatment. In the de-escalate trial, patients whose PSA decreased to 0.2 or less after 6 to 12 months of MAB were randomized to continuous MAB and intermittent MAB to observe the overall survival and the proportion of patients who did not restart MAB. In the Libertas trial, patients will be randomized to apalutamide plus intermittent or continuous ADT according to PSA 0.2 response after administration for 6 months. And ADT will be restarted when PSA is 10 or higher or PSA doubling time is less than 6 months. In the APA-ENZA short trial, patients with low volume will be randomized to discontinuation or continuation of AR pathway inhibitor after 12 months of administration, and clinical progression-free survival will be assessed. In the ADREAM trial, after 18 to 24 months of ADT, both ADT and AR pathway inhibitor will be discontinued, and treatment-free survival at 18 months will be studied. If the PSA becomes 5 or higher, treatment is resumed. So in summary, treatment de-escalation aims to maintain effectiveness with less toxicity. There will be many options and no one-size-fits-all treatment. When the deep PSA response, radiologic, and symptom remission are achieved, de-escalation can be administered by suspending ADT, AR pathway inhibitor, or both. And the shared decision-making is necessary. Thank you for your attention.